Ensure privacy, introduce yourself, explain to the patient you will be performing an abdominal examination.
I'm Jin. Therefore, I will be your nurse today. I'm here to perform an abdominal assessment on you. So let me make sure that you are the right patient.
Perform an hand hygiene.
I'm going to wash my hand and come back.
Let's start by asking the patient some subjective questions. Do you have any change in appetite? Do you have any loss of appetite? Any difficulty swallowing? Any foods you cannot tolerate? Any abdominal pain? Any nausea or vomiting? How often are your bowel movements? Any past history of GI disease? Tell me all the foods you ate in the last 24 hours. Do you take any medications? I'll begin my physical examination by inspecting the abdomen from more than one angle for shape, contour, and movement. The abdomen should be symmetric bilaterally and either rounded and flat when the patient is in a supine position. An abdomen is a scaphoid or sunken in might be signs of dehydration or malnutrition. I will note that the skin color and examine the skin for lesions and scars. Likewise, I will observe the location and configuration of the umbilicus, which should centrally be located with no signs of umbilical hernia. I will look for any pulsations or movements. I may see pulsations from the aorta. Marked pulsations may represent hypertension, aortic insufficiency, abdominal aortic aneurysm. Next, I will use a diaphragm of my stethoscope to auscultate bowel sounds in all four quadrants. I'll begin in the right lower quadrant of the ileocecal valve area. Normal bowel sounds are high-pitched tickling sounds heard every 10 to 30 seconds in all the quadrants. On the other hand, hyperactive bowel sounds are heard infrequently and may indicate gastrointestinitis or bowel obstruction. The absence of bowel signs may indicate paralytic illness. Now, using the bell, I will listen over the aorta for any vascular sound or bright, which is an abnormal finding. Abdominal percussion is the next step. It is useful for dilating the outlines of solid tissues. For example, the liver or the spleen, or the enteral bowel masses such as the tremors or fecal masses. The percussion tones that I am likely to hear are the percussing the abdomen included dullness, tympany, and resonance. Dullness is heard over the solid organs such as the liver and spleen. Tympany is commonly heard over the areas that contain gas such as the stomach and intestines. Now I'll turn the patient to the right side. Fluid will gravitate to the dependent side if ascites is present. The last part of the abdominal assessment is palpation, during which I'll use my fingertips to feel all over the abdomen symmetrically for rigidity, masses, and tenderness. Light palpation is done to determine how soft or hard the abdomen is. Deep palpation is done to feel the masses and identify any tenderness. Rebound tenderness. If any pain is noted or reported, be sure to test the rebound tenderness. To do this, I'll gently press over the painful area, gradually increasing pressure within my patient's ability to tolerate the discomfort. Then quickly release the pressure. If releasing the pressure increases the pain, I'll document the patient has positive rebound tenderness, a common finding in appendicitis. CVA tenderness. Lastly, percussion over the costovertebral angle, where the rib cage meets and the spine to asses for the kidney tenderness. I'll thumb my hand with the ulnar edge of the other fist. A positive result elicites pain. The text concludes my examination, so I will perform hand hygiene and document my findings in an appropriate flow sheet.